Welcome to the Oxygen Alliance YouTube channel, where we bring you videos on installation, maintenance, and various trainings on oxygen equipment and devices. If you have comments and or questions, drop them in the comment section below or write to us info@oxygenalliance.org. Remember to like our videos, subscribe to our channel, and hit the notification bell.
Hello everyone, thank you for joining us for today's partner talk brought to you by the Oxygen Alliance. We host these talks every second and fourth Thursday of the month from 2 p.m. to 3 p.m. Central African Time, where we discuss various oxygen-related topics. My name is Elizabeth Tabaraba, a biomedical engineer with the Oxygen Alliance, and I'll be your host today. I'm hosting this call from Lilongwe, Malawi, and I would love to know where you're joining us from. So please type your name and location in the chat. If you would like to be added to our emailing list and receive notification of our upcoming events, drop your email in the chat also. Today, we are privileged to be joined by a esteemed guest from the USAID Global Health Bureau and the USAID Global Health Supply Chain Program, as well as UNICEF Newborn Health Innovation Specialists and biomedical engineers. So they will share invaluable insights on respiratory ecosystem equipment with a deep dive into the continuous positive airway pressure CPAP. So without further ado, let me now hand over the stage to Leah Greenspan, who will introduce the team to us and then kickstart the presentation. Welcome, Leah.
Thank you so much, Elizabeth, and thank you all for attending and taking the time out of your day, whether it's morning, afternoon, or evening. Thank you, Elizabeth, for the intro again. My name is Dr. Leah Greenspan, and I am a senior newborn advisor at USAID with a focus on small and sick newborn work, commodities, as well as leading on the oxygen ecosystem for USAID. I am joined here with all of my friends and colleagues from our supply chain team, Mr. Tama Kamlam and Brittany Stoller, as well as my friend Sarah Likahari Baharam from UNICEF Innovation. UNICEF. You see Florin George on this slide. Though he's not here, and no, he will not be presenting. A lot of the slides and the information that will be shared come from work with him and because of him. So thank you so much to all the speakers and all of the team from Oxygen Alliance for having us here today. Next slide, please. Oh, this slide, thank you. So why are we here and why are we having this deep dive? I hope many of you were able to attend or view the neonatal oxygen related equipment presentation in January from Oxygen Alliance. It was an excellent presentation, and on the right you see in the outline the content that was discussed. Introduction to neonatal oxygen related equipment with these 4 devices, how the newborn has a delicate nature, what oxygen equipment is specifically used for neonates, and the very, very critical care and maintenance of all of these pieces of equipment. From this meeting, we all agreed that we needed a really, really deep, technical, intense dive into CPAP and specifically bubble CPAP. Now, I'm a neonatologist, so I'm very passionate, and I'm joined here by all of you because of your own passions as well. Next slide, please. So we're going to watch these videos twice, looking at and thinking about different things. So let me share the first video with you, and I just ask you, think, listen, and look. Can you hit the video, please? So go ahead and play it, Tama.
Okay.
So as you can see out here, you see the baby retracting. Try it again. You see the xiphoid retractions, you can see the seesaw breathing, and what you can hear is the baby grunting. And what you hear is this sound, which sounds very different from the baby's cry. On the next video that Tama will play in a minute, this baby has been put on CPAP. I don't know the time elapsed, But take a look at the breathing now that the baby's supported. Go ahead, Tama. You can see that this baby is breathing very, very comfortably. And in the background, you don't hear that baby cry. You don't hear that sound of the baby grunting. And what grunting is doing is the baby trying to use its own body to create PEEP, actually. PEEP, the positive air and expiratory pressure that you receive from the CPAP. So that's the point of this video, is how putting this baby on CPAP changes the work of breathing for this individual. Next slides, please. I wanted to just take you all through this slide that shows you what the oxygen ecosystem looks like for all. These are the majority of the components of the ecosystem, starting from oxygen generation, but also including interfaces, monitoring devices, the critical health workforce, spare parts, and of course, the very important power supply. And the point behind this slide is that increasing access to oxygen is way beyond just the gas alone, and it's part of a broader system. So any patient on oxygen, regardless of the condition, requires this complex system. Next slide. Now, the visual on the left of this slide is blurred out on purpose because I just showed it to you and I don't want you to focus on that. But in the ideal world, we have all of these things within that respiratory system for all. And then we drill down on the right of the slide that shows us the elements of this system, in addition to everything on the left, that is specific for the newborn. The newborn needs specific devices and interventions for resuscitation that is different for other patients. The newborn and the mother needs medications as part of the respiratory ecosystem, oxygen saturation monitoring, and I'm specifically saying CPAP for the moments, and oxygen during stabilization and transport. So this is the complex respiratory ecosystem for all on the left and specific to the newborn on the right. Next slide. So don't panic here on this slide. It's very complicated and I don't want to go into too many details, but the point of this slide is there are two major modes of positive pressure generation, and we need to keep this in mind. Bubble CPAP and ventilator CPAP are continuous flow, where the pressure is determined by the force applied to the surface area of the valve. I had to go back and review this. It's been a long time. Bubble CPAP uses the distal end of the expiratory limb that is submerged in water to a depth equal to the CPAP provided in both phases of respiration. Sarah will speak to you more in detail about that. But ventilator CPAP is also a constant flow. And the CPAP in a ventilator, the ventilator alters the pressure provided by altering the size of the expiratory orifice, and the patient's expiratory flow opposes the current flow from nasal prongs and generates CPAP. As a clinician, and what I really want you to understand here in the continuous flow is that the pressure gradient is independent of the flow. So when you're putting 10 liters of flow into this bubble CPAP system and the bubbles are going crazy in the water, that doesn't mean you're getting any more pressure. It actually has negative effects, but again, the pressure here is independent of the flow. In the variable flow, which is the flow opposition with fluidic flow reversal during expiration, this is the infant flow driver or a gas jet ventilator. Now this is quite complex and I don't want to spend too much time or scare anybody about this, but if you just orient yourself to this image on the bottom, you see this little baby. Now he's with sunglasses and pacifier just for fun, but I wanted to orient you that that's where you have the baby. And the infant flow driver uses the Bernoulli effect, which is gas flow in the direction toward the nair. So you can see the inlet jet where the gas is coming in toward the baby during inspiration. And there's another effect which flips. As you can see in exhalation, the gas is going down. So the flow flips, the flow of the inhaled flips into the expiratory limb during expiration to maintain stable CPAP throughout the cycle. Now, the important point to remember here is that the pressure that is generated is dependent on flow. When you increase the flow in these types of devices, you are increasing the pressure. So I just wanted you to keep all of that in mind, and let's forget about all of this now. So next slide, please. What about the effects of CPAP? I think about the effects of CPAP like a balloon. You see this baby and you see the lungs and you see the alveoli or the air sacs in the lungs. On the left, those are normal alveoli, balloons, so to speak, that are blown up with air. On the right, you see those alveoli collapsed. So what the effects of CPAP do is they keep these balloons slightly open. Now, if you've ever blown up a balloon, which most of us have, those first few breaths to get that balloon to blow up the first time are really hard. But once you get it blown up just a tiny bit, the rest of the way to fill the balloon is actually much easier. And that's how CPAP works. It increases the functional residual capacity and works off what is remaining in that balloon. It prevents alveolar collapse, so prevents those balloons from collapsing, so to speak, and then requiring more air to open up. And in preterm babies, these alveoli are very, very sticky because of the lack of surfactant. So effects of CPAP also involve conserving surfactant and stimulating growth of the immature lungs. And you can read on your own those other effects of CPAP. Next slide, please. Now I want to take you as a clinician to the WHO recommendations for preterm and small and sick newborns. And you can see in the circle that these are the interventions for care of complications that relate to the respiratory ecosystem that either have current guidelines being updated like the resuscitation guidelines, or guidelines are being developed. Next slide, please. So let's take a look into this book. Now remember, I had shown you the respiratory ecosystem specific for newborns includes medications. Let's take a minute to speak to that. Medications such as antenatal corticosteroids, caffeine citrate, kind of like the coffee I'm drinking now, and surfactant. Quickly, antenatal corticosteroids are therapies that are given to mothers, pregnant mothers with a high likelihood of preterm birth for the benefit of the baby. WHO has several conditions under which mothers with high likelihood of preterm births are given antenatal corticosteroids. And for the purpose of this conversation, I will highlight the fact that this condition must be met as well as the others, but preterm newborn must be able to receive adequate care, including resuscitation and respiratory support, including CPAP, for that mother to meet criteria for antenatal corticosteroids. Caffeine citrate, this drug is a methylxanthine, the drug of choice according to the WHO for the treatment of apnea of prematurity, extubation of preterm infants before 34 weeks, as well as prevention of apnea in babies born before 34 weeks. The last medication I want to speak to here is surfactant, with a focus that that drug is appropriate at the level 3, and USAID and others are currently focusing on level 2 and above and below. But surfactant is recommended for intubated and ventilated newborns with RDS. And we're not going to spend too much time on that. Next slide, please. Still within these this WHO recommendations, here are the 3 major recommendations for CPAP. We all are very aware CPAP for preterms with clinical signs of RDS. But for those that are less than 32 weeks, we want to consider giving those babies CPAP even before they have clinical signs, because they have a very high likelihood of having RDS. The third bullet has brought about a little bit of confusion from many people who have reviewed these guidelines. And let me try and explain this to you, bringing you back to that very stressful and confusing slide around the different modes of pressure support for CPAP. So according to these WHO recommendations, when you're choosing CPAP for preterms, bubble CPAP may be considered rather than other pressure sources, the sources that I showed you previously. So I hope that explains why I went through that with you, and also this recommendation. Next slide. I think we've learned this in the previous presentation in January, the indications for bubble CPAP, and you can see them written here on this slide, and you're welcome to review. If you can skip to the next slide, please. This is mine and Thomas' favorite slide, I have to say. We can all on this webinar agree, and I think most people agree, that oxygen is essential for life. But it is human nature to think that if some is good, more is better. But I want you really to leave this presentation with this point. More oxygen is not better, because oxygen can be toxic if provided in high, it is given in too much, because oxygen can be toxic. As clinicians, as medical providers, regardless of your profession, our first priority is to do no harm. So when you're giving 100% oxygen to babies, you need to think about this slide. So oxygen toxicity can lead to 3 things: blindness or visual impairment, brain injury, and chronic lung complications. So looking at the left, you see, I see the right? Looking at the left, who is that? Most of my presentations from a global perspective, most people know this incredibly iconic musician, Stevie Wonder. And if you know Stevie Wonder, you know that he's blind. But Stevie Wonder was not born blind. Stevie Wonder was born premature and exposed to unregulated oxygen within an incubator, without pulse oximetry and without thinking about the potential long-term complications. Now, that was quite some time ago, but still thinking and understanding that increased oxygen can lead to retinopathy of prematurity, which is becoming the leading cause of child blindness across the globe. The next visual is you see that oxygen toxicity can lead to brain injury. And the visual on the right is this is not a newborn baby. This is an infant, and he is receiving supplemental oxygen. So oxygen toxicity can lead to chronic lung disease and long-term pulmonary complications. So please take away that oxygen is essential, but we must remember to avoid the unintended consequences for our interventions. My next slide, please, and my last slide. I think this slide is really cute and it's really important, and this slide really speaks to USAID. As you can already tell, I like graphics and I try and keep things light even in difficult situations. USAID has 25 priority countries. In our 25 priority countries, we have 8.4 million births. We assume that almost half of those newborn preterms will have RDS. On the right, you see caffeine, oxygen therapy, and any CPAP. These 3 interventions will improve millions of newborn lives annually in our priority countries. Each one of these cute little lungs, unfortunately, represents 200,000 lives that can be impacted or improved. So maybe it's fortunately with the interventions that we've discussed. So I'm now going to thank you again for your time and hand it over to Sarah to take us through the rest of the presentation.
Thanks, Leah. I'll keep my camera off. My name's Sarah Leah Mobarhan. I am a biomedical engineer working as the Newborn Health Innovation Specialist for UNICEF, and I'm also based out of Malawi, so hopefully my internet will be strong throughout the rest of the call. So Leah's already sort of gate-posted for us what CPAP is and how it works. And just to sort of take us back to that, I'll take us through this circuit of a traditional bubble CPAP. And maybe this looks familiar to some of you on the call. Maybe you're more familiar with other types of CPAPs. We'll come to that a little bit later in the session. But just for a traditional CPAP, this is typically the way that it's set up. To think about the way that the CPAP works, you can have another analogy. So imagine a straw placed in a glass of water. So when you blow air through the straw, you create bubbles. And in a similar way, bubble CPAP blows air through a tube that's partially submerged in a container of water. And the depth of this tube in the water creates a certain amount of pressure, just as it does when you're blowing into a glass with a straw. And this air, along with the pressure that's created by the bubbles, is delivered to the baby's lungs through special prongs. And this constant pressure, as Leah was saying, there's different types of pressure, but this constant pressure from the bubble CPAP helps to keep the baby's airways open, which makes it easier for them to breathe. So all of this is just around helping babies breathe more effectively. And this continuous positive airway pressure device is like having a sort of gentle, continuous breeze that helps keep these air sacs in the lungs open. And what this means is that it allows for better oxygen exchange, but it also helps the baby to breathe more comfortably and effectively. And as Leah mentioned, when it comes to oxygen, too much is a problem, too little is a problem. And a continuous positive airway pressure product like this helps to make sure that we're delivering the right blended flow at the right pressures to really facilitate breathing. If you just click once, yeah, and then we stop there. So I'll take us through the different components of the CPAP. So the first component is a type of blended flow. Typically, this is encompassed by an air source and an oxygen source. So usually ambient air is used, often drawn in by a built-in air pump within the system. And this is typically filtered in some way before being connected to the oxygen source. So as I was saying, the blended flow is typically made up of a flow meter or of some type of oxygen source and some type of air source. So typically ambient air is used, it can be filtered. And then for the oxygen source, this depends on the product, depends on the type of CPAP device that you have, but it can typically be provided through any oxygen source. So whether that's a PSA plant that's providing walled oxygen, a tank that's been purchased, or an oxygen concentrator. These gas sources come into flow meters, and typically there are separate flow meters for both air and oxygen, which can be adjusted to adjust the volume of each of the gases. And the settings on these flow meters determine the proportion of air and oxygen that go into the blended output. And what this means is that you can adjust the percentage of oxygen in the breathing gas mixture that's delivered to the patient, or the FiO2, using the flow rates. So when these air and oxygen pass through their respective flow meters, they're typically combined using some type of Y connector or a similar mixing device. And this is where the blending of air and oxygen happens to form one single stream that goes into the rest of the bubble CPAP. So some CPAPs will have an internal pressure regulator, and this ensures that this happens at the same pressure. Some will only have a Y connector with no additional pressure regulation. And that means that for each product, it's important to look at the specifications for the device to make sure that the oxygen source that you're using is appropriate for your specific CPAP device. So if we click again, Tama, and one more time, from the blended flow, it typically goes into some type of heated humidifier. And this is one of the big areas, I would say, that typically in many of the models that we have available in this part of the world, there's not typically heated humidification available, but it is still safe to use, and it is actually more comfortable for the patients, and there's various reasons why that is. But for the purpose of this, just in how it works, this step adds moisture to the medical gases that have been delivered into the humidifier. So that makes them more comfortable and also safer for the patient's respiratory tissues. So newborns are very delicate. We know this. I mean, their skin is delicate, their mucosal, their mucus is delicate as well. And if you humidify the air that's coming in, you can help prevent dryness and irritation, and make it easier for the patient to breathe in. So if we click again, we now get to the next stage, which is the transmission to the patient. So now the airflow has gone through the blender to the humidifier, and then is being delivered into the patient's area. So this is typically done through prongs for newborns. And you can see here that we have inspiratory tubing and we have expiratory tubing. So in the inspiratory tubing, this is the air that's coming directly from the heated humidifier, and it's being inhaled by the newborn. And this happens during the inhalation phase. And the purpose of this flow is really because we have this gas mixture that's being inhaled by the patient, and then they also have the airway pressure that is being created by the back pressure in the pressure regulator that is making sure that the lungs stay open long enough to get this air into the lungs so that appropriate gas exchange can happen. And then you have the expiratory flow, which is after the patient. No, Tama, if we can go back, we're still on the patient. If you just go back one slide. No, back. Back again. And again, keep going back. Yeah, stop here. Perfect. Thank you. Some technical difficulties, but we are all doing our very best. So in the expiratory flow, this is the movement of gas from the patient's airways back to the CPAP device. So think about this as inhale and exhale. So in the exhalation, the patient exhales. So the expelled gas is any carbon dioxide, any residual oxygen is directed back, and the flow pushes it away from the patient so that they're no longer inhaling carbon dioxide and things like that. And then it's also, during this process, still providing a constant flow of gas to maintain the lungs. So the airways don't collapse, as Leah showed, the balloon stays open. All of this loops into the next component, which is the pressure regulator. Perfect. So this is typically a bubble generator with a tube that goes into the water. And what happens is the depth of the tube's end under the water surface determines the amount of back pressure that's keeping the infant's airways open. So the continuous flow of the gas that started at the blender, went through the humidifier, went past the patient, is now in the pressure regulator bottle. And this continuous flow helps to maintain a stable pressure in the delivery system. So even though the patient is exhaling, their airways still stay open. So now we can go to the next slide. So this was a very long explanation for how this works. And as I said, this is a typical CPAP circuit. So there are lots of different types of CPAPs that are currently available on the market. You can see some of them here. And they all have different infrastructural requirements that make them more or less appropriate for certain settings. So as I said before, the type of oxygen that you select, very important. In many hospitals in Malawi, there's no high pressured air. So if you need to have high pressured medical air, then maybe those products are not appropriate for your hospital. So it's important to consider all of these different infrastructural elements, and we'll go back to that a little bit later in the presentation. But as you can see here, these are many different models of CPAPs, but they all work fundamentally in the same way. There's a pressure driver, there's a pressure regulator, there's a patient circuit, and there's the option for humidification. Next slide. I'll hand over to Brittany and Tama for the implementation of CPAP in Ghana.
Thank you so much, Sarah. Good afternoon and good morning, everyone. My name is Brittany Stoller, and I am joining you today from the USAID Global Health Supply Chain Program Procurement and Supply Management, or GHSC-PSM project. Today, I will be introducing you to some of the lessons learned from a recent assessment in Ghana. But first, some background information. A 2018 statistical survey showed that neonatal mortality rates in Ghana remain high at 25 per 1,000 live births. Previous assessments of the situation in Ghana indicated challenges around availability of medical equipment necessary for the care of small and sick newborns, or SSNBs. In 2023, the GHSC-PSM project, in collaboration with the Ghanaian Ministry of Health and Ghana Health Services, conducted this assessment of the newborn health ecosystem in northern and upper west regions of Ghana. The assessment surveyed 51 health facilities that recorded at least 300 deliveries in 2022, including 24 hospitals. The goal of this study was to increase stakeholder understanding of the newborn health landscape and identify opportunities to enhance newborn health programming. This assessment also documents gaps across a patient's oxygen journey, with a particular focus on small and sick newborns. Next slide, please. In this comprehensive assessment, findings were shared regarding all of the categories currently seen on your screen, including neonatal services provided, available infrastructure and equipment, and human resources. My colleague Tama will now speak further to some of those findings.
Thank you so much, Brittany, for introducing us to the assessment that was conducted regarding available equipment for medical care for newborn. I will walk you through some of the findings, not all of them, but with the particular focus on the CPAP area, because that is really the topic that we are diving in today. And what we saw through the assessment is that CPAP was only present and available at level 3, meaning at mainly at the hospital. And we saw that about 21% of the hospital survey had standard CPAP. About 38% had improvised CPAP, and about 42 had either standard or improvised CPAP. So quite a bit of mix, but overall still low numbers, indicating that there are still gaps out there. And if we are able to basically see that those kind of number in Ghana, we can extrapolate and kind of have a sense of what is happening in other countries and, identify certainly certain gaps. Overall, about over 50% of hospitals with improvised or homemade CPAP did not have blended oxygen. And we know from the previous slide how critical blended oxygen is to provide safe and effective oxygen to newborns. So something to also keep in mind, either for advocacy or when it comes time, for example, for us staff working overall in provision of medical care to children, to always think about that necessity. Standard CPAP driver with blended oxygen, again, was at about 21%. So it's really critical to be able to work towards increasing that number. One aspect that also impacts the supply chain, it's ensuring that we have enough consumables to keep those machines working. It's critical as we are working towards preventing medical graveyard or medical equipment graveyard. So always ensuring that we are having enough accessory or consumable to get the machines working. Now, overall, what are some of the key findings from the assessment conducted in the two regions of Ghana? First, we looked at availability of medical equipment, including CPAP devices, and it was very clear that there was quite a number of gaps, indicating a lack of sufficient medical equipment to provide adequate care to small and sick newborns. It's an area that necessitates more action. Secondly, looking at forecasting and procurement of medical equipment, there were also gaps there. For the majority of the health site survey, we noticed that consumable or devices or even medicine were not procured in the right window when they need to. So oftentimes it was really through emergency orders, which obviously exacerbate the challenges that the site's already facing. Third, we looked at capacity building. There was need there indicated to help staff, including technician and biomedical engineer, to be well adjusted to the equipment that were being present at site or being procured. So it's an area where I think all of us can always come together and ensure that, you know, as we're procuring an equipment, that we are also receiving the proper training needed and the proper monitoring in order to effectively use those equipment to provide safe and effective care. Fourth, maintenance protocol. Maintenance was quite an issue. In some area, even just the existence of basic maintenance tools were not available. So again, indicating another area where there's much work to be done. And all the above points are tied to the major one, which is funding. We all know that without money, it's difficult to get a lot of things done, especially in our area. And the funding can only come when we also build strong advocacy. And the last point I want to make here is that advocacy is really, I believe, the work of every single one of us, part of this ecosystem. That's why you see we mentioned the respiratory ecosystem and not just part of it, because the belief is that as we all come together, whether tech, biomedical engineer, nurses, neonatologists, and other aspect of people working in this space, we have a stronger voice to be able to engage stakeholder and ensure that we have increased support for this work to continue and provide adequate care to small and sick newborn. I'll pass the next slide to Sarah to walk us through the different type of CPAP that we see available.
Thanks very much, Tama. And so I'll sort of reflect back on what we presented earlier on, that there are many different types of CPAP that are available right now that are placed in the market for countries with limited resources. So you can see some of them here, and I know that some of these will be familiar to those of you on the call. So Bayou, Diametica, Pumani, I think are all very familiar to those of us, certainly in Malawi, I think in Kenya as well, and in a few other countries around here. And each of these have their own positives and negatives. So as Tama mentioned, so much, and as Brittany mentioned, so much depends on the infrastructure that's available at your facility and the specification requirements from the different products. And at UNICEF, we actually don't feel that the perfect CPAP currently exists. So you can see here that none of these products really have all of the requirements that we would like these products to have. A few of them have some of them, but none of them really fit all of the needs. So it's important when you're selecting the CPAP that's correct for your hospital, or when people are offering up products that fill the continuous positive airway pressure niche for you, that you consider the different specifications that each of these products require. Next slide. And in line with that, we at UNICEF Supply Division, ooh, the picture is so messed up. That's fine. At Supply Division, we are working on developing something that we're calling a procurement. And what this is a guide based on facility level information and user input to tell you what you need to buy, in what quantities, and with what consumables and spare parts. You can go to the next slide. So you can see a snapshot of what this looks like. So we ask about information that's specific to your standard of care. And we're talking about this right now in the context of bubble CPAP. But as Tama and Leah have already mentioned, we can't have bubble CPAP without a comprehensive approach to newborn care. And so when we suggest this tool, it takes infrastructural requirements. So you can see here compressed gas systems, load shedding, poor power quality, and it incorporates that into an algorithm that provides a specific suggestion for the products that we currently have in the supply catalog at UNICEF. So when you put in your facility information, you know that the product that you get will be appropriate for your health facility. You're not going to get a CPAP that requires compressed medical air. You're going to get a CPAP that has exactly the right level of infrastructural needs for your health facility. This also, as Tama mentioned, sorry, if we can just go back to the previous slide. I know we're running a bit short on time, so I'll run a bit more quickly through the later slides. But as I mentioned, this procurement also considers those things that are essential to making sure that these products keep running. So it gives you an estimate for the consumables that you might need. So for bubble CPAP, that's patient circuits, nasal prongs, and gives you a tailored to your health facility estimate that you can use when you're procuring. So you can't just, so you won't just procure the CPAP, you'll procure the CPAP, the filters, the patient circuits at the same time. Next slide. And all of this means that we build our maintenance culture. So I think a lot of us on this call are biomedical engineers or technicians. And within UNICEF, and I'm sure USAID as well takes this approach, we really cover three main pillars. So durable products, educated staff, and guided procurement. So we've mentioned the durability of products, making sure that they're right for your health facility and for your infrastructural requirements, making sure that our staff are well trained in using these products. So as biomedical engineers, we're often called to provide user training to our staff. And if they don't ask us for user training, oftentimes that creates other problems that need to be solved by biomedical staff. So we want to make sure that we take that education component and we really take that on ourselves as biomedical engineers to lead in our health facilities. And then guided procurement. So making sure that what we're selecting is appropriate for our health facility. Next slide. And then we want to make sure that we're advocating for our products. So again, thinking about this thoughtful purchasing, we're not just buying a unit, right? We're not just buying one bubble CPAP and calling it a day. We're buying the bubble CPAP, we're buying the consumables, and we're buying the spares. And without that, we can't provide comprehensive care. As I said before, making sure that we have adequate HR. So for bubble CPAPs, I think this might have come up in the previous presentation as well, but there is additional human resources that are required to make sure that these products are monitored on newborns effectively. And then for us as biomedical engineers, we need to make sure that we have a comprehensive health technology management ecosystem in place, because you can't provide service only for the bubble CPAPs. We're all responsible for providing so much service to each of our health facilities. And it really is beyond just bubble CPAP into the entire HTM ecosystem. And then in terms of the product lifespan itself, we want to make sure that we're advocating for proper decommissioning and life cycle based repurchasing. So when you buy a CPAP, if the projected lifespan is 8 years, we plan for 8 years from now having another CPAP that can replace it. Next slide. At UNICEF Supply Division, we have specific requirements that we put in place for quality assurance. And for us, that means that we accept only products that have been regulated by one of the 5 founding members of IMDRF, the most famous of which I would say are the US FDA and the European CE. And we also require for CPAPs an ISO 13485 quality management system. And both of these things come into place just so that we can make sure that the products that we're getting are regulated internationally, are approved, so that the products that come into our health facilities we know are effective and have been tested to provide appropriate pressure, appropriate and stable considerations for work of breathing, for oxygen blending. Next slide. I'll hand over, I think, to Leah for this slide, but just to note that we on this presentation are biomedical engineers and also clinical specialists and also other non-clinical specialists. So it's important for us to have a multidisciplinary approach when it comes to the implementation of products like these. Leah?
Thank you, Sarah, for taking us through your slides so eloquently and spending time to really help the audience understand and fill in any gaps if they have any in their knowledge and understanding of CPAP and where CPAP sits within the system. This slide really shows you that it takes a multidisciplinary health workforce that is a blend of clinician and non-clinical specialists, just like the audience on this presentation. We must have support from clinicians and other staff at the health facilities for clinical case management, and we must support to increase healthcare facilities and the health system capacity to optimize the use and maintain oxygen resources, all within the ecosystem as well as in the health system itself. So it is now exactly 8:50, so I think we should switch over to one more, switch to the next slide, please. It is time for Q&A, so people please come in for questions.
Well. A round of applause to our presenters today for a quite fascinating discussion on the respiratory ecosystem equipment. And as it was already said, now it is time for questions. So feel free to raise your hand and I'll make sure to acknowledge you and also grant you an opportunity to ask. You can also just type the question in the chat. And also, as you can see, we have poll questions. So please, let's vote and respond to the poll questions according to the knowledge that we have towards this topic. Any questions? Okay, I can see that Maui has raised a hand. So please, Maui, can you go ahead and mute yourself and ask your question?
Thank you very much, Elizabeth. Thank you so much, Leah and your team. That was very wonderful. My question is on the purity, also pointing towards the issue of oxygen toxicity. So we have been trying to do some research around what is the correct purity of oxygen that can be given to neonates. And in our research, some people have been arguing that you can give high purity oxygen to neonates as long as it's not for an extended period of time. And others point out to say you need to bring the purity down or blend the purity with medical air so that it's you don't risk oxygen toxicity. So I just wanted to find out what's the recommended standard for oxygen for the purity that has to be given to neonates. Thank you.
Thank you for this excellent question. Go ahead.
Yeah, sorry, and maybe just flow rates as well. I may have missed it, I'm not sure, but maybe you can also comment around the flow rates as well.
So thank you for this excellent question. And there have been many studies over time that look at disability and death. And at this current, we used to maintain saturations, around 88 to 93%. But we saw that there was an increase in death and disability. So now the ideal saturation is somewhere between 90 and 95%. That's what you're looking at your pulse oximeter to read. So that's your oxygen saturation at the patient level. How you get to that point is where you dial your different flows, whether it's medical air and oxygen, or however you use your device, you want your blended oxygen to maintain the saturation at 90 to 95%. And then as you asked about ideal flow, you're looking at your PEEP, not your flow, if you're looking at bubble CPAP. And that's what I alluded to, and Sarah went into a deep dive on the depth of the expiratory limb. And you want your PEEP to be somewhere between 5 and 8 for newborns, depending on their work of breathing. And that's something that you change according to how the patient changes. There's excellent resources online. Nest 360 actually has a lot of information about clinicians' guides for these types of things. And just to circle back for one point, if you're using a variable flow device, then the flow does directly impact the PEEP, but right, because those were the two differences between the continuous flow and the variable flow. With the continuous flow, like bubble CPAP, the flow does not affect the PEEP, where the variable it does. So you want, in the variable, you dial your flow to maintain a PEEP of around 5 to 8. Over. I hope that answers your question.
Yes, it does. Thank you.
Thank you so much for that question and also the response. Any more hands, please? Any more questions?
Leith has an excellent question in the chat, and I think it's really important. I don't know if Leith, you want to ask your question, or if Sarah, you want to just bring up Leith's question and the answer.
Yeah, I'm happy to do that. So I think that the question in the chat is around the cost of local CPAP, local bubble CPAP versus the cost of commercial bubble CPAPs, because the range is so much wider. So just to quote from Leith's question in the chat, the cost of equipment required to make the device is less than $2 versus the cost of conventional BCPAP ranging from $5,000 to $18,000. And the question was, what can be done to reduce the cost of the commercial products, as they are preferred and are safer for use than the more improvised CPAPs. So what I'd put in the chat is that there's current efforts at UNICEF in market shaping to try and decrease the prices of available bubble CPAPs. But as I mentioned earlier in the presentation, we don't think that the perfect CPAP is currently available in the market. We do think that there's still work that needs to be done in this space to improve it and make it more accessible. And it really depends on this type of group to try and improve our options and encourage manufacturers to keep on developing. Because we can advocate for this at the UNICEF level, but really without buyer engagement and without market forces, it is difficult to encourage manufacturers to get the prices down to where these products can really be accessible and save lives. All of that to say that maybe Leah, if you want to mention some things about this and how that impacts the use of improvised CPAP.
Yeah, no, thank you so much. And as I had mentioned earlier, the dangers of improvised CPAP are real. We really do see generations of blind children, or children that are visually impaired, children now that go into adolescence and adults with chronic lung disease from non-communicable lung disease and brain injury. Now, Leith, I think your point is critical, but throughout the years, and as the newborn space has gone from just survival to thriving, and from just resuscitation to now small and sick newborn, the costs of these devices have changed. And there now are other devices that the lowest I've seen is a device that can be purchased for around $400 that can provide blended CPAP, up to, the ideal gold standard of the Fisher-Paykel bubble CPAP device. So there is a broad range, and that I think is relatively new. And there are innovations constantly being developed, but it is a process, and it's an expensive process. But we do need to be continually pushing this needle, and know there is no perfect CPAP device that will work in every context. And even within countries, the context can change from, in northern Ghana, what they can provide in terms of the infrastructure is very different in Accra, and I think that applies to all countries. But what we really need to make sure we do is we do no harm and avoid 100% oxygen and unregulated pressures to think about the long-term outcomes of the babies. I hope that answers your question. And Lee, thank you very much for bringing that very important question up. Back to you, Elizabeth.
Thank you so much, Leah. And we also have here a question from Katie and Sambo, where she is asking, say, where does the exhaled air go? Does it mean it remain in the bottle, or is there some outlet considering it's a closed system? So I believe you'd like to understand how now the circuit continues.
I'll take that as well. So a great question. And there's the same answer that I'm going to give is in the chat. But the exhaled air is usually passed through the pressure regulator tube where it creates bubbles and is expelled into the air. And typically sorry, I'll speak slower. Typically the pressure regulator bottle has some holes or some openings that are up at the top of the bottle that allow this to happen. So it's not a closed system when it comes down to the pressure regulator bottle. It is only a closed system until it gets to the water.
And she's specifically speaking about the bottle with the water at the end. So thank you for that. I think we're at time. So back to the Oxygen Alliance team to close us out, please.
All right, thank you so much. And this marks the end of the call. And thank you for being here with us. And thank you to our guests today, Leah and your team, for the wonderful presentation. It has been an educative session indeed. So if you have further questions, you can just email us at info@oxygenalliance.org. And also you can find copies of this discussion on our YouTube channel and Facebook page, all profiled as Oxygen Alliance. So thank you all for joining us today. You have been a wonderful audience, and we expect to see you again on the upcoming calls. Until next time, goodbye.